Hello, everybody. My name is Tiberio Frizzoli. I'm an interventional cardiologist with the Henry Ford Heart and Vascular team, and I will be your moderator today for the lecture. Welcome and thank you for joining us for our Healthy Living Lecture event on atrial fibrillation, what you need to know, hosted by Henry Ford's Senior Healthy Living Program. This afternoon, we will have the pleasure of hearing from an esteemed electrophysiologist here at Henry Ford, Dr. Arfaat Khan, on the topic of atrial fibrillation, what you need to know. Dr. Khan specializes in treating all kinds of heart rhythm disorders, from heart rhythm disorders such as atrial fibrillation and atrial flutter to other kinds of heart rhythm disorders, whether they require pacemakers, defibrillators, or special types of procedures. Following Dr. Khan's presentation, we'll have a question and answer session. We ask that you please type any questions you have into the chat box, and please do not share any personal medical information in your question. Please turn off your cameras for a smoother experience for all, and please note that your microphones have been muted. This lecture is being recorded and will be available to listen to again on the Healthy Living Lecture Series webpage at henryford.com/healthyliving. And now it's my distinct pleasure to introduce Dr. Arfaat Khan.
Good afternoon, everyone. Thank you, Dr. Frizzoli, for doing the introduction. I really appreciate it. And I'd like to thank everyone for joining me today to talk to you about atrial fibrillation, what you need to know. Just give me a few moments to get my presentation up on the screen. So again, thank you everyone for joining us today. I'll do a brief presentation going over atrial fibrillation and what everyone should know about atrial fibrillation. To go over the agenda, my name is Dr. Arfaat Khan. I'm an electrophysiologist with the Henry Ford Health System. Atrial fibrillation is one of the main conditions or disorders that I treat on a day-to-day basis. And today what we're going to talk about is, number one, we'll talk about what is atrial fibrillation. Number two, we'll go over the types of atrial fibrillation. Number three, we'll talk about who is at risk for atrial fibrillation. Next, we'll talk about atrial fibrillation and the risk of stroke. Next, we'll talk about the treatment options for atrial fibrillation. And lastly, briefly about catheter ablation for atrial fibrillation. So what is atrial fibrillation? We see in the news and on TV, you hear more and more things. Sometimes if you're watching TV, you may see certain commercials about the different medicines that are there, blood thinners. But what is actually atrial fibrillation? Well, atrial fibrillation is the most common type of the cardiac arrhythmias. And what happens in atrial fibrillation is that the upper chambers in your heart, known as the atria, start to beat very erratically. Normally, your heart beats around 60 to 100 beats per minute. What happens in atrial fibrillation is that the top chamber of your heart, it takes over and starts making the top chamber contract around 500 times a minute. The bottom chamber of the heart, which is responsible for your pulse, reacts it to that top chamber beating that fast. And fortunately, it's able to control somewhat of the impulses. But still, your heartbeat can be very erratically, very irregular, and can beat anywhere between 60 to 170 to 200 beats per minute. So you can sort of feel like your heart flip-flopping. It's the most common arrhythmia in the world. Currently in the United States, we have about 5.5 million people diagnosed with atrial fibrillation. And as the years progress, the expected frequency or prevalence of this condition is expected to rise to even higher numbers. And people that are usually above the age of 40 are at the most at risk of developing atrial fibrillation. Another name for atrial fibrillation is called Afib or AF, and we commonly refer to as Afib. Now, it's very important to understand the types of atrial fibrillation, as not all patients have the same type of atrial fibrillation. And really understanding the type of atrial fibrillation gives us an idea of how to actually treat the condition. Initially, when you're first diagnosed with atrial fibrillation, you may go in and out of the condition. you may have episodes where your heart is racing fast and then spontaneously you'll convert to normal sinus rhythm. This is what we call paroxysmal atrial fibrillation. And it occurs immediately after the first episode of atrial fibrillation. And you may be in this for months to a few years. And as time progresses, what happens is that these episodes become longer in frequency, and the time duration where you're actually in a normal rhythm is much reduced. Which takes us to the next aspect, which is called recurrent atrial fibrillation, or also known as recurrent persistent atrial fibrillation. What we mean by persistent atrial fibrillation is that if you're in the condition continuously for more than 7 days in duration, and the only way you can get out of the condition is your doctor, your cardiologist, or your electrophysiologist has to give you either some sort of medicine or has to put you to sleep to what we call cardiovert, or convert your heart back in normal rhythm. And then lastly, we have what we call long-standing persistent atrial fibrillation, and then what we call permanent atrial fibrillation, in which you've been in atrial fibrillation continuously for over 1 year, which is long-standing persistent atrial fibrillation, or permanent atrial fibrillation, where your doctors have tried therapies to get you out of atrial fibrillation, but unfortunately, because you've been in the condition for that long, it's very difficult to get out of it. The important thing to understand about atrial fibrillation is that it is a chronic condition. It is progressive. So the earlier you act in the condition, the better chance of success you have. The longer you wait till it becomes persistent or becomes a permanent condition, it's very difficult for any of your physicians to get you out of that abnormal heart rhythm. Who is at risk for atrial fibrillation? Well, there are many people that are at risk, and there are certain things that are what we call modifiable risk factors and non-modifiable risk factors. Obviously, the non-modifiable risk factors are things such as age. Probably the most important or most likely thing that can cause atrial fibrillation is age. As you do get older, atrial fibrillation becomes more higher. The risk of developing atrial fibrillation becomes higher. So we commonly see atrial fibrillation in older patients, above 40, 50, 60, and as you get older and older, the chances of atrial fibrillation increase. Having said that, I have seen young patients, even as young as 30 years of age, have atrial fibrillation as well. Family history also plays a role. If you have a sibling, brothers or sisters, there can be some genetic component to develop an atrial fibrillation, although it is rare for this to happen. And heart disease, having blockage in the arteries of your heart, having heart failure, having a weak heart, these are all risk factors which are non-modifiable to develop atrial fibrillation. But what are some of the things that you can control that lead to atrial fibrillation? Number one is sleep apnea. There's certain things that you can look out for. If your partner says that you're snoring at night or that they may stop breathing at night, you may have sleep apnea. Number two is obesity, being overweight, inactive. These are all things that can actually lead to atrial fibrillation. Alcohol consumption. Heavy drinkers are more at risk for developing atrial fibrillation. Smoking is another risk factor which can lead to the development of atrial fibrillation. Caffeine consumption and also stress are also things that can lead to the development of atrial fibrillation. Who treats atrial fibrillation? Well, I can tell you that it takes a village to manage and to treat atrial fibrillation. First and foremost, the most important person is your primary care physician. This is the physician or the person that you see on a day-to-day basis, or I should say on a regular basis, yearly at least, if not maybe even more frequent than that if you have other associated conditions. And they will probably be the most important people or the initial people that may diagnose you with atrial fibrillation. Secondly, your cardiologist. Your specialist your primary care physician will send you to further manage and treat your atrial fibrillation. And often, the cardiologists are the doctors or the physicians that actually send you to patients like me. I'm the electrophysiologist who basically specialize in the management of atrial fibrillation. We particularly deal with only the electrical aspects of the heart. So what are some of the tests you can do to diagnose atrial fibrillation? Number one, an electrophysiology study can be performed. This is a study basically looking at the electrical system of the heart. It is an invasive procedure. But typically, we don't start out with this. This is more of a latter thing that we do. We initially start out with getting an EKG. And the key to diagnosis of atrial fibrillation is being able to identify the abnormal rhythm on an EKG. So a 12-lead EKG is basically a snapshot of what your heart's electrical activity is doing at the time the EKG is taken. Now, some people may not have atrial fibrillation all the time. They may go in and out of atrial fibrillation. They may be in it for a few minutes and they're back in normal rhythm. If the EKG is done at the time when the patient is in normal rhythm, you may not catch it. So what are some ways we can help identify or monitor longer? Well, there are 2 or 3 different ways to do this. Number one is called a Holter monitor. This is basically a continuous EKG that you can wear up to 2 weeks in duration. Then you have monitors called event monitors, which can go up to about 30 days. And then you have special recording devices called loop recorders. These are actually inserted into the subcutaneous tissue beneath your chest, which actually stay in for about 3 to 4 years. And these can detect atrial fibrillation up to that duration as long as they're in your body. How they work is that they send or transmit information to us on a monthly basis and let us know if you are having atrial fibrillation and can tell us exactly the burden of atrial fibrillation. So sometimes with patients that are known to have AFib, we may consider placing this in patients to help us better manage and understand the burden of the condition. And after we do some therapies such as medications or ablations, it may give us a better idea of whether or not our treatment strategy has been successful. An echocardiogram is another test that we do to help guide us in terms of the management of the patient with atrial fibrillation. It gives us an idea of what your heart function is, whether there are any associated reversible risk factors, such as any valve issues or any weak hearts. These all play a role in terms of helping us manage you. And lastly, something that's come up recently over the past few years are smartwatches. We've seen many patients that have come in to see us diagnosing atrial fibrillation on their smartwatch. And actually, this is actually a very important tool which gives you a good idea of how much atrial fibrillation you're having. The journey for patients with atrial fibrillation can be very complicated. And there's a lot of what we call trial and error involved. Initially, you may be undiagnosed for years. Your symptoms may present such as palpitations. You may think that they're actually anxiety issues or panic attacks, but in actuality, they actually may be a heart rhythm disorder. Then once you get diagnosed, your primary care physician, as I mentioned before, may send you to a cardiologist. We may try medicines, such as medicines to help slow the heart rate down, or medicines aimed at decreasing the amount of atrial fibrillation you have. You may go back into normal rhythm, however, you may relapse, and therefore you may have to see an electrophysiologist at that time, which may further alter your medicines, or may recommend you undergo a cardioversion or a procedure called an ablation. Now, what are the symptoms of atrial fibrillation? Does it really affect the quality of life? Well, there are many patients that don't even know that they have atrial fibrillation. They may be completely asymptomatic, and they may be only detected incidentally when they've come in to get tested for something else. Contrary, there are many patients that actually have a lot of symptoms from atrial fibrillation. Some of the common symptoms are general fatigue. Walking from, the grocery store to your car may cause you a lot of shortness of breath. Basically, exertional shortness of breath. Going up the flight of stairs is more difficult than it was, 6 months ago. Palpitations or feeling your heart is flip-flopping, feeling a skip beat sensation. You're feeling very anxious. You're feeling very weak, just tired, sweating. These are all signs, symptoms that could represent atrial fibrillation. Now, regardless whether or not you have symptoms or not, atrial fibrillation does put patients at stroke or at risk for having a stroke. Now, the studies show that atrial fibrillation actually increases your risk of stroke by more than 5 times. And nearly 1/3 of strokes are caused by atrial fibrillation, and the ones that are caused by atrial fibrillation are actually more deadly and more dangerous. Now, why does that occur? Why do patients that have atrial fibrillation, why are they at risk for stroke? Well, the whole theory and the pathogenesis behind this is that your top chamber of your heart is beating 500 times a minute. And when it's beating that fast, it's not squeezing anymore. It's basically quivering. And when it quivers, blood that's in that chamber does not circulate. When blood does not circulate, clots can form, and these clots can dislodge and lead to a stroke. As you can see on this diagram, you have your heart here in the patient, and if a clot forms, it goes up these vessels and can lodge into your brain. And once it does that, there's a decrease in blood supply to your brain, a particular part of the brain, which can lead to a stroke. So whenever your chamber doesn't contract, whenever blood doesn't circulate, clots can form. And that's why it's very important for patients that are at risk for having a stroke with atrial fibrillation. We may need to put them on blood thinners to prevent this stroke from happening. Now, what are the signs of a stroke? Sudden numbness or weakness of a face, of an arm, of a leg, confusion, trouble speaking, difficulty understanding speech, sudden trouble with walking, dizziness, loss of balance, sudden trouble seeing in both eyes. You may see double, you may see blurring of vision, or severe headache with no known cause. One important way to recognize this and know this mnemonic is called B fast. B meaning balance, loss of balance. Eyes, your eyes may seem droopy, you may have blurred vision. Face, you might not be able to move one side of your face, or you may feel that you're actually drooling from the side of your mouth. Arms, you may not be able to move your arm, or you may feel numb and weak. Speech, you're not able to speech, or not, I'm sorry, not able to speak clearly. And T, time. Time is very important. As soon as you have any of these symptoms, it's important not to wait, and you should call 911 immediately. Now, does everyone have the same amount of risk if they have atrial fibrillation for development of a stroke? No. There are certain risk factors that we use to calculate and to guide our therapies and who should be on a blood thinner and who shouldn't be on a blood thinner. The scoring system that we use is called the CHAS-VAS scoring system. But essentially what it is it's a mnemonic that we use to remember on what to ask patients when we decide on whether or not the patient needs a blood thinner. Number one, is your age more than 65? Number two, if you're more than 75, you have twice and more risk. Number three, are you female? Females have more risk than males. Do you have a history of congestive heart failure? Do you have hypertension? Do you have vascular disease such as a heart attack, blockage in the arteries of your legs, or any plaque in your aorta? Or have you had a prior stroke, which actually carries a very high risk, or are you diabetic? These are all things that we use to calculate, and frequently what we do is that for males that have 2 or more risk factors, we recommend for them to be on anticoagulation, and for females that have 3 or more risk factors, we recommend them to be on anticoagulation. Now, the main thing about atrial fibrillation, there are 2 different aspects to treatment. Number 1, and the most important, is reduction in the risk of stroke. And number 2 is management of the atrial fibrillation condition itself. Now, reduction of risk of stroke is done by anticoagulation medicines, which if you are high enough risk factors, you should be on that. Or if you can't tolerate anticoagulation risk factors, there is a procedure that we can do called left atrial appendage closure. In terms of management of atrial fibrillation, we have medicines that are used to help control the heart rate if you should go into atrial fibrillation, and medicines that are actually used to keep you out of atrial fibrillation altogether. There are actually procedures to eliminate atrial fibrillation, such as ablation and cardioversion. And it's also important to address the lifestyle issues that we discussed further, addressing sleep apnea, addressing obesity, addressing your diet, stopping smoking, stop drinking alcohol. These are all things that we have to address when we see if you have atrial fibrillation. Now, how is atrial fibrillation managed? Number one aspect is what we call rate control. If you're chronically in atrial fibrillation, if you've been in it for a very long time, for many years, and we can't get you out of it, our focus is mainly aimed at keeping the heart rate under control. We don't want it to race fast. And typically we can give medicines for this, or as a last resort, a pacemaker. Number 2, rhythm control. This is mainly meant for patients that are in the early condition, early onset of atrial fibrillation. They've just been diagnosed within the last year. They're flip-flopping, they're going in and out of atrial fibrillation, what we call paroxysmal, or they've been in atrial fibrillation for less than a year. In these patients, we can try what we call medicines or procedures such as an ablation. Thirdly, lifestyle changes, regular exercise, eating a heart-healthy diet, not smoking and watching your alcohol and caffeine consumption. And lastly, as I mentioned, an atrial fibrillation ablation procedure, which is a special procedure designed to help reduce the amount of atrial fibrillation episodes someone can have. Now we talked about the left atrial appendage closure and also how to reduce Afib-related stroke. As I mentioned, medicines should be the mainstay and the most important thing that you do to prevent a stroke. Medicines such as blood thinners are typically what we prescribe if you have high enough risk factors. If you're not tolerant of blood thinners, such as you've had prior bleeding, you're falling, you're unstable on your feet or unsteady, or you have a very active lifestyle and you're worried about having injury with a blood thinner, then there are other alternatives, and one of them is called left atrial appendage closure. The common blood thinners that you may be on, warfarin, which is a very old, very effective medicine, is very cheap. Other medicines that have come out recently are called Eliquis, Pradaxa, Xarelto, and Sevasa. These are all medicines which are very effective. very good for prevention of stroke and atrial fibrillation. But because the blood thinners can actually prevent a stroke, at the same time, they do have risk factors that can cause bleeding. So whenever you talk to your doctor or your cardiologist, try to address and weigh in the strengths and the risks and the benefits. Is from the blood thinner? Is your risk of stroke higher or is your risk of bleeding higher? And depending on that, you can make an informed, a shared decision about what is the best treatment for you. Left atrial appendage closure is someone that is a procedure that we do for patients that may not be a good long-term candidate for blood thinning. And what we do is basically we go into the heart, in an area of the heart where the clots originate from, and that area is called the left atrial appendage. It's basically a pouch attached to the left top chamber of the heart. And this device, either the Watchman device or the Amulet device, which are two commercially approved devices in current times, are placed to seal off that area. And once it does that, essentially it traps the clots that are there and prevents from new clots from forming, thus reducing your risk of stroke. But again, we don't give this to every patient. We give this to mainly patients that we feel may not be good long-term candidates for blood thinning. The treatment options for atrial fibrillation are three options. Number one, cardioversion. Number two, medicines. And number three, catheter ablation. Cardioversion is basically a procedure in which a low-dose shock is given when a patient is sedated to reset the heart's normal electrical activity. You have to be on blood thinners in order to do this because there is a risk of stroke. What happens is that your heart, which is in atrial fibrillation and beating 500 times a minute, once it gets shocked, it goes back to normal rhythm. So if the clot is there, that can dislodge and cause a stroke to happen. That's why it's very important to be on a blood thinner before and actually after a cardioversion. But this essentially resets and restores the heart's normal electrical system. Now, with this condition, since you're not going to the cause or the root of the problem, there is a high rate of atrial fibrillation recurrence. That's why many times what we do is that we actually give medications along with doing a cardioversion, and these are basically called antiarrhythmic drugs. These are medicines that we may start before the cardioversion, and the main goal of this is either to convert you into normal rhythm or after the cardioversion is done to facilitate and maintain a normal rhythm after. And as I mentioned before, it's very important to be on a blood thinner both before and after the cardioversion is performed. Sometimes medications can be overwhelming and troublesome. Antiarrhythmic medications that we give, some of them require inpatient monitoring in the hospital when we first administer them. Some of them require you to come in for frequent EKGs. Others require long-term monitoring. There are certain medicines that have many side effects. So you have to monitor certain things in your bloodstream every 6 months, such as your liver tests, thyroid tests, also looking at your lungs. So some medication may have too many side effects. They may not be desirable for patients, and some of them may not be effective. So what if medications aren't working? What should you do? Well, another option for you could be catheter ablation. And nowadays, if you're healthy and have if you're in the early stages of the condition, catheter ablation can actually be offered as a first-line therapy for treatment of atrial fibrillation. Now, what is the catheter ablation? It is basically a procedure in which you're completely sedated. And what we do is that we go into the heart, in the left top chamber of the heart, where atrial fibrillation is coming from, and we basically burn or freeze the cells that cause the atrial fibrillation from happening. It's an outpatient procedure that is done under general anesthesia or deep sedation. It has about a 1% risk factor profile. You go home the same day. You're advised to take it easy for the next 4 to 5 days after the procedure. But it's done by placing IVs in your leg. And as I mentioned, it can be done either using heat, called radiofrequency, or freezing, called cryotherapy. Catheter ablation is a low-risk procedure. The overall risk of the procedure is around 1%. They include bleeding in the leg where we put the IV in. There's a risk we could puncture through the wall of the heart, which can cause fluid to form around the heart. Risk of that is about 1%. We'd have to put a tube in to drain that fluid out. The other risk includes the risk of stroke. Overall, the risk of stroke is pretty small nowadays because we have you on blood thinners before and after the procedure. I would say less than 1 in 1,000 patients. The benefits of it, there are some studies that show that it may be more beneficial than medicines that are used to rhythm control your heart. Definitely, if you failed a rhythm control medicine, the next step is to do an ablation procedure. It's been shown that these procedures actually do improve quality of life. They do help slow the progression down of atrial fibrillation when it goes from paroxysmal to persistent to the permanent stage of atrial fibrillation. And it may provide good symptom relief. And also there also is some data to show if it's done early enough in the condition, there may be some data to suggest what we call decrease the risk of death or long-term risk of stroke associated with atrial fibrillation. Now, how to know if the ablation is something that's right for you? Number one, talk with your doctor, talk with your cardiologist, talk with your electrophysiologist. But mainly things that we look at are patients, have they failed drug therapy? If you've already failed drug therapy, then yes, ablation is the right choice for you. And a lot of times we may be offering ablation therapy as a first-line therapy, even before you fail drug therapy, particularly if you feel that you're in the early stages of the condition. Now, it's very important to act quickly when diagnosed with atrial fibrillation. Don't wait. Come and see your primary care doctor or your cardiologist. And the important thing I want to address today is that atrial fibrillation is a progressive condition. So it's important to seek treatment as soon as possible to improve your quality of life, control the arrhythmia, and reduce your risk of stroke. And if for patients that are interested in learning more, you can visit our website. It's www.henryford.com/afib_doctor. And we have many patient stories on there, a lot of information for you. You can go on there and learn how to set up an appointment as well. And I thank you very much for listening today. We'll be happy to take some questions, and I'm going to hand it back over to Dr. Frizzoli. Thank you.
Wow, thank you. That was great. That's such a wonderful discussion about a topic that, frankly, is oftentimes a bit confusing, even for doctors, let alone for patients to understand. So thank you, Dr. Khan, for that. I'm looking here in the chat box, and I don't see any questions right now. If you have any questions, please do go ahead and type them into the chat. And while we're waiting for questions, Dr. Khan, perhaps I could ask you a question. You mentioned some of the potential treatment options, which include medications, cardioversion, ablation. I know this is complicated sometimes, but can you explain how you decide when you treat any given patient with each of those options?
So, Dr. Fazoli, thank you for that question. I think it's a very important question and something very important to discuss. So whenever I have a patient that I see with atrial fibrillation, the first thing I'm looking at is to see what stage of atrial fibrillation they're in. And I sort of explain to them, just like how cancer has different stages to it, atrial fibrillation has different stages to it as well. I'm not saying that atrial fibrillation is cancer, but sort of how we address cancer. If we're in stage 1 of cancer, you want to be aggressive and treat it. You don't wait for it to get to stage 4. Same thing in atrial fibrillation. If you're in stage 1 of atrial fibrillation, meaning that you've just been diagnosed with atrial fibrillation, you go in and out of atrial fibrillation on your own. The episodes are infrequent. The time between episodes is far apart. You're actually a very good candidate to undergo some sort of treatment. I don't think you should ignore it. So in some sort of treatment, meaning either giving medicines for it or doing an ablation for it. There have been more and more data and studies that have come out over the previous few years that have actually suggested that earlier treatment of atrial fibrillation leads to much better long-term benefits rather than just waiting and letting it progress. So there actually have been studies as well. So the first thing is, number one, treat it. Treat it with either a medicine or ablation procedure. Try to keep it at bay, prevent the progression of the condition. Then I tell my patients that head-to-head, what is better? There have been some studies to suggest that ablation may be superior than medicine. Ablation may be superior in preventing the progression of the condition of atrial fibrillation to a more stage 2, stage 3, stage 4 condition. So I give the options to the patient, but at the end, it's their decision of what they feel comfortable doing.
Wonderful. And I know that the way we treat AFib has shifted a little bit over the years with new knowledge, and we've gotten a little bit more aggressive in treating atrial fibrillation earlier in the natural history of the disease. We have a question here in the chat from Sue. If AFib is caused by a leaky valve, is there anything that can be done to correct the leaky valve and eliminate the AFib?
So that's a very important question. And it's very interesting because Dr. Frizzoli, who is moderating the session, is actually an expert in treating leaky valves. But I'll address the atrial fibrillation. and maybe I can have him address a little bit about the leaky valves. So it's very, and this is a very important thing to understand, is that a lot of times atrial fibrillation can be the primary condition or primary disease state in itself. But several times it may be secondary to something, such as having hyperthyroidism, right? If you have hyperthyroidism where your thyroid is acting up, it's going to cause your heart to race fast. You can do all the treatments in the world for atrial fibrillation, but until you fix the thyroid condition, your atrial fibrillation is not going to get fixed. So same thing with the leaky valve. If you have a very, very leaky valve, a very tight valve, without fixing the valve first, atrial fibrillation will not get corrected. And there's nothing that I can do to fix that leaky valve. Sometimes we may recommend to go to actually a surgeon to get that valve fixed. But nowadays, we actually have a lot of therapies and treatments that are available by the same way we do an ablation, we can fix those valves. And I'll actually have Dr. Frazzoli maybe comment on that because he is actually an expert in doing that.
Yeah, and this question highlights how there is such an interplay between the different portions of the heart. The heart is a muscle, the heart is an electrical organism, the valves of the heart. And Dr. Khan is exactly right. If you have a leaky valve, that puts you at risk of atrial fibrillation. It also works the other way around. If you have atrial fibrillation, that puts you at risk of a leaky valve, because the atrial fibrillation will cause the atria, the receiving chambers of the heart, to enlarge, and the valves live inside a portion of the atria called the annulus. And as the annulus stretches, because the AFib has been there for a long time, the valve becomes leaky. So which is the chicken and which is the egg? But the short answer is, because valve conditions can be a cause of changes in the heart and a cause of atrial fibrillation, it only stands to reason that if you treat the valve condition, you may reduce the burden of atrial fibrillation. Furthermore, treating a severely leaky valve in and of itself has benefit in terms of reducing your symptoms of congestive heart failure and in some cases prolonging your life. And Dr. Khan and I, we work together all the time to co-manage these patients because they go hand in hand. They're concomitant disorders. It's very common for patients with leaky valves, with arrhythmias like atrial fibrillation, to need both an electrophysiologist and an interventional cardiologist.
And picking back, on that, something that's very important to understand is that if you have, we talked about different risk factors for atrial fibrillation, the modifiable risk factors such as sleep apnea and obesity. There's actually been a lot of studies to show that treatment of the atrial fibrillation by itself is not effective or it's very dismal unless you correct these underlying risk factors. There have actually been studies to show that patients that have undergone atrial fibrillation ablation, and in 50% of them, they did not address the sleep apnea or the weight loss. And in 50% they did address the weight loss and the sleep apnea. And the group that underwent the ablation along with addressment of the sleep apnea and weight loss did a heck of a lot better than the other group who we would not address those things. So again, when we treat atrial fibrillation, we have to treat the whole body of the patient, not just the rhythm itself, but hypertension management, being good on good high blood pressure medicines, making sure your weight is down, making sure that you're eating healthy, making sure that you're being treated for your sleep apnea. If you have valve problems, fixing these valve problems. These are all very important things that everything needs to be addressed to get the best success rate.
Are there any other questions from the chat?
I see a lot of patients with atrial fibrillation that address the question of, do I need to be on blood thinners long term? And I think that the most important thing to determine that is what your risk factors are. And then, we have many people that don't want to take blood thinners and are thinking of alternatives. And the devices that have come out, left atrial appendage occlusion devices, are very good devices. They're actually devices that are meant to eliminate the need for blood thinners. But the important thing is that we have to understand is that it's not meant for everyone. It's mainly meant for patients, at least now, that are not good long-term candidates. So how do you know if you're not a good long-term candidate for blood thinner? Well, number one, something that your physician and you should jointly decide about. But patients that are falling, that have prior bleeding, that are unsteady on their feet, or we've had some young patients who are actually very active. I've had a patient that actually is a police officer that wanted to get off blood thinners because of their just physical, job that they have. So the general point that I want to make is that blood thinners are the best medicines or the treatment for reduction of risk of stroke. But if you're not a candidate for blood thinner, then yes, the surgical procedure for left atrial appendage closure is a good alternative.
Dr. Khan, can you explain to our audience this left atrial appendage closure procedure with the Watchman Flex or the amulet? How invasive is it? Is it a surgery? How long can a patient expect to stay in the hospital for this procedure? What's the safety and efficacy profile of this procedure?
So left atrial appendage closure devices have been out for about 6, 7 years now. Actually, probably longer. I think about 10 years now it's been out. And over time, the devices have been modified to the point where they have become extremely easy, very safe to implant. And the procedure is done by way of what we call transcatheter-based techniques, meaning that through an IV in your leg, you may require general anesthesia, but a lot of places are doing it just with simple conscious sedation. And what we do is we put an IV under ultrasound guidance into your leg. And through that IV, we run a wire up into the heart. We advance that closure device into the area of the heart called the appendage, where that basically seals off the appendage. It takes about literally 30 to 40 minutes to do. You're in and out of the room within an hour to hour and a half. You have to lay flat for a couple hours after the procedure. You're up and around and ambulating that same day. A lot of time we may send you home that same day, or if we just want to keep an eye on overnight, we may watch you overnight. But again, it's a very safe, very easy procedure. The risks are less than 1%. And actually, a lot of my patients are getting it done. Patients in particular, like I mentioned, who may not be the best candidates long term. But again, it's nothing like open heart surgery. It's a very easy, very simple procedure where you are pretty much back to your normal activities within 2 to 3 days.
Great. Sounds like a great alternative to blood thinners in the appropriate patient. We have a question in the chat from Pat. Great question. Dr. Khan, are all palpitations AFib?
Pat, that's a very good question. And I want to say that no, palpitations can be from a variety of different conditions. Palpitations can occur just from premature beats. They can occur from premature beats from the top chamber of the heart, premature beat from the bottom chamber of the heart, or they could be atrial fibrillation as well. But the most important way, as I mentioned, to diagnose atrial fibrillation is to have what we call ECG documentation. And that's why the longer you monitor someone, either with a Holter monitor, event monitor, or what we call loop recorders, which are actually devices that we implant subcutaneously beneath the skin, which stay in for 3 to 4 years, which gives us a more long-term monitoring for the patient. Those help us diagnose what atrial fibrillation is. But no, all palpitations are not meant to be coming from atrial fibrillation, and frequently they're not. They can just be skip beat sensation, or you may have a rhythm called SVT, where your heart starts to race very fast for a few minutes, and then all of a sudden it gets back down to normal. Again, that's a normal heart rhythm. It doesn't put you at risk for stroke, and it's something that's curable. So if you are having a lot of palpitation, the first step is to actually get a documented evidence of what exactly it is. And I would recommend getting some sort of monitoring, probably a Holter monitor or an event monitor, starting out with an EKG.
And correct me if I'm wrong, but the reason this question is so important is because there are palpitations that mean AFib, and there are palpitations that mean SVT or premature beats, like you said. And those diagnoses are very different in terms of their implications for causing stroke, for causing congestive heart failure. Is that right?
Yes, very much so. Very much so. I mean, the risk, having atrial fibrillation versus just having premature beats, one condition has an increased risk of stroke, whereas the other one has really no implication other than just symptom management. So that's why it's very important if you're having palpitations to figure out exactly what it's from. Nowadays, many patients, have, smartwatches. I have one, on right now. And with the more modern smartwatches, you actually get a real-time EKG of what your heart rhythm is doing at the time of these palpitations. So I think it's something that it's very important to invest in if you are a patient that are feeling palpitations but haven't been diagnosed with anything, despite some monitoring. I do get a lot of patients that come in and see me and have been diagnosed with atrial fibrillation based on their smartwatches. And I think the era and the way that technology is evolving, these smartwatches are becoming better and better as the days go on in terms of diagnosing these arrhythmias.
You can tell that Dr. Khan is the electrophysiologist wearing the smartwatch, and I'm the plumber interventional cardiologist because I'm just wearing a standard watch. Are there any other questions from the chat? Dr. Khan, I have a question. Oh, no, here we go. We have a question from Lauren. Oh, another great question. So how do you decide which medication? And I assume, Lauren, that you're meaning medications to control atrial fibrillation, or maybe you also mean blood thinner medications. So Dr. Khan, in general, how do you decide which medication to use for atrial fibrillation?
So the way I decide on which medication to use depends on what type of atrial fibrillation you have. If you come to me at the late stage where you say you have permanent atrial fibrillation, you've been in atrial fibrillation for over 3 years, 4 years in duration, it's very unlikely that I'm going to be successful in terms of getting you out of atrial fibrillation, either by doing an ablation procedure or doing a cardioversion. So in that case, I may just recommend a simple medicine, such as a beta blocker or a calcium channel blocker, aimed at just controlling the heart rate. Our goal is not to get you out of atrial fibrillation. Our goal is to control the lower chamber's response to the top chamber's problem where the atrial fibrillation is coming from. So our goal is to keep your heart rate below 100 beats per minute. And for many people, that's good enough. For many people, as long as you control the heart rate, they actually feel very, very good. They have no symptoms at all. Now, if you come to me in the early stages of the condition, where you're going in and out of atrial fibrillation, and there's a chance, and I think a good chance, of getting you back in normal rhythm, then I'll probably recommend, number one, a medicine, what we call anti-arrhythmic drug, to help get you back in normal rhythm. And there are different anti-arrhythmic drugs out there. There are about 5 to 7 different drugs that we use commonly. And then how we decide which medication to use is really dependent on what risk factors you have. In certain patients, we can't give it if you have heart disease. In some patients, we can't give it if you have kidney disease. So depending on what your risk factors are, how your heart function is, whether or not you have kidney problems or not, we decide on which antiarrhythmic drug to give. But again, that's only given for if we think we have a good chance of getting you back in normal rhythm. In terms of blood thinner, what medication we decide, as I mentioned previously, there's a medicine called Coumadin, which is still out, which is a very effective medicine. It's not expensive, but it does require a lot of monitoring. It does interfere with some of the foods that you eat. You do have to go in once a month to get your blood level monitored, and it can fluctuate a lot. More recently, there have been other medicines that have come out. You see commercials for them. Eliquis, are also known as apixaban, rivaroxaban, also known as Xarelto, dabigatran, also known as Pradaxa. These are more, commoner medicines that have come out. They are more expensive, but they're easier to take. They don't require any monitoring of your blood levels. They reach the normal therapeutic range within a couple hours after they're being given. And actually, there are less risks for causing a bleed as compared to warfarin or Coumadin. So typically, when we prescribe blood thinners, if you have high enough risk factors, we will probably prescribe these newer medicines.
Great, great. We have another question here. This is from David. Dr. Khan, can the catheter loosen deposits in the artery? Can the catheter loosen deposits in the artery? And I think the question in general is, what are some of the complications related to the catheter?
So when we do the ablation procedure, we're doing it through the vein. And typically, when we talk about deposits in the artery, I'm assuming that you're maybe talking about plaque buildup in the arteries. Do we check the arteries of the heart? As an interventional cardiologist like Dr. Fazoli would do, we're looking at potential for blockages. So when we do an ablation procedure, we're focusing strictly on the vein aspect of the heart. We don't go over to the arterial side of the heart. So we don't loosen any deposits in the arteries. We strictly, localize into the veins. So no, when we do this, we're only looking at, in an ablation procedure, only the electrical aspect of the heart. We don't really look at the plumbing aspect of the heart. And there's really no reason for us to look at that. We do testing beforehand to make sure that's not the case. And if we do think that there could be a component where you may have a blockage, or a blockage could be causing this arrhythmia, then at that point, even before doing the ablation procedure, I would refer you to someone like Dr. Fazoli, who's an interventional cardiologist, to further evaluate you, who may recommend getting a stress test done, or may recommend actually getting a heart catheterization done, where they actually look at the arteries and see if there's a blockage in the arteries of the heart. But no, we do not loosen the deposits in the arteries by doing an ablation procedure.
Great. Are there any other questions? Go ahead and type them in the chat if there are. We do have a few more minutes with Dr. Khan. Well, if there are no other questions, this brings us to the end of our event. Thank you for all the great questions, and on the behalf of Dr. Khan and the Senior Healthy Living Program, thank you so much for joining us to learn more about atrial fibrillation. Thanks again, and have a great weekend.
Thank you, everyone. Bye-bye.